Sometimes you just want to go really deep on a topic, not just skim the surface, but really understand the structure, the whole process, the why. Maybe it's for yourself, maybe you're dealing with healthcare stuff, but you want that insider feel like you're really mastering it. And that's exactly what this deep dive is for. Today we are plunging right into how medical pros figure out problems with our body's framework, the musculoskeletal system.
Yeah.
Bones, joints, muscles, nerves, the whole lot. Our mission: to unpack the systematic way they take a patient's history and do a clinical exam for musculoskeletal issues. And we're using a solid source excerpts given to us from Bailey and Love's Short Practice of Surgery. We're going to cover everything in this material piece by piece, so you feel like you've got that expert level grasp.
And it's so vital because really this process, it's the absolute bedrock for diagnosing pretty much any MSK condition, common things, rare things, urgent things. It all starts here. A good history and exam really guide everything else, the tests, the treatments. It's fundamental.
Okay, let's unpack it then, starting right at the beginning. Taking the history. It's way more than just firing off questions, isn't it?
Oh, absolutely. Think
Yeah.
of it more like a carefully choreographed interaction. Yeah. Designed to get the best info before you even ask what's wrong. There are these essential first steps. The source really stresses hygiene, proper hand hygiene, non-negotiable. Introduce yourself clearly. Check the patient's name, date of birth, confirm identity. You also need to think about whether a chaperone is needed and if one's available. And always, always explain what you're going to do. Get their verbal okay, their consent, and make sure they're comfortable. These aren't just niceties. They build trust, respect. They're foundational.
Right, setting the stage properly. So once that's done, how do you actually get them talking about the problem?
You start broad. An open-ended question, like, what seems to be the problem? Or tell me what brought you in today. You want them to describe it first, completely in their own words, let them lead initially. The source also suggests asking what they hope to get out of the consultation, their expectations.
And then you start digging into the specifics of the complaint itself. The source mentions the 3 Ws.
Yeah, the 3 Ws. They give you that initial timeline, the framework for the presenting complaint. It's when did it start? What exactly were you doing when it began? And was the onset sudden, like bang, it happened, or more gradual, creeping up over time?
Got it. Beyond that main issue, what other specific symptoms should you be asking about, things they might not mention up front?
Good question. You need to actively ask about associated symptoms. Things often linked to MSK problems. The source lists the key ones. Pain, obviously, but also swelling, instability, maybe they say their joint gives way. Mechanical symptoms, too, like locking, clicking, clinking sounds or sensations during movement. Any loss of power or strength. Any altered sensation, numbness, tingling, pins and needles. Asking about these helps you narrow things down. Mechanical stuff often points to internal joint issues, like meniscus tears, altered sensation. That shouts nerve involvement.
And how does this problem actually affect their life? That seems super important for context.
Absolutely critical. Assessing functional impairment is key. How does it impact their activities of daily living, their ADLs? You tailor the questions. Upper limb, ask about personal hygiene, dressing, feeding themselves. Lower limb, can they put on shoes and socks? Can they stand okay? Walk, manage stairs. Understanding these limitations gives you a real feel for the severity, the impact on their quality of life.
Okay, so moving beyond the current problem, what about their wider medical background?
Right. The past medical history, or PMH, super important. You need to find out about any comorbidities, other conditions they have. Things like diabetes, asthma, previous heart attack, stroke, anything that might relate to the MSK issue or, crucially, affect their fitness for anesthesia if surgery is needed. And definitely ask, have they ever had problems with anesthesia before? Any adverse reactions?
And previous surgeries?
Yes, absolutely. Any relevant past surgical history, especially operations on the affected limb or related systems.
Medications, too. That feels like it could have major implications, especially heading towards potential surgery.
Huge implications. A detailed drug history is a must. The source highlights specific ones to ask about. Anticoagulants, blood thinners, big impact on bleeding risk. Steroids affect bone health, wound healing. Aspirin. Immunosuppressants affect healing, infection risk. Also the oral contraceptive pill and hormone replacement therapy. Knowing their meds is vital for planning and risk assessment.
The social context, too. That adds another layer.
Definitely. It helps you understand the patient as a whole person. Tailored treatment. The questions need to be relevant to the condition. The source lists key points. Age, obviously. Hand dominance, essential for upper limb problems. Their job, how does this impact work? Do they have dependents? Alcohol, smoking habits, big impact on healing. Hobbies, do they have home help? What's their accommodation like? Stairs, access. Are they using walking aids? And assessing their cognitive status, their mental test score, is important for understanding and consent. Each piece adds to the picture. Hand dominance for a wrist issue, home setup for someone needing mobility aids. It all matters.
Does family history come into play much with MSK conditions?
Yeah. It can, yeah. The source says to ask about family history of MSK diseases. Some conditions definitely have a genetic link.
So pulling all that history together,
Mm-hmm.
it's really not just ticking boxes, is it? It's building this detailed individual picture for that specific patient.
Exactly that. It's systematic information gathering. The source summary reinforces it. Introduce yourself, explain consent, open question presenting complaint, history of PC-associated symptoms, functional impairment, PMH, PSH family history, drug social history. Following that structure ensures you build that solid, comprehensive foundation before you even lay a hand on the patient.
Right. History gathered. Now, onto the physical examination. The source introduces this really elegant framework. Apley's simple, systematic approach. Look, feel, move.
Apley's method is brilliant. It provides that essential structure. And look, it actually starts the second you see the patient. It's a general inspection before you zone in on the specific area. Are they using walking aids? How do they carry themselves? How do they even walk into the room? You look at the whole person. The source mentions checking hands for rheumatoid arthritis signs or eyes for Horner's syndrome. Droopy eyelid, small pupil, less sweating on one side. Surprisingly relevant sometimes. You're scanning for obvious limb or spinal issues from afar. Johann Friedrich Horner described that syndrome, by the way.
And a really key part of that initial look is watching how they walk their gait.
Gait analysis tells you so much. The beat cycle has two main bits. Stance phase, when the foot's on the ground bearing weight about 60% of the cycle, and swing phase, when it's off the ground, the other 40%. You watch them stand, then walk back and forth. Note any aids. The source has a great table on different limps. Like a long limp, often seen when the other leg has arthritis. The head dips to the good side, rhythm is dash dash. Incoordinated, like in cerebral palsy, no regular rhythm. Muscle weakness, maybe hip abductor weakness. Head moves side to side like a windscreen wiper. Pain, that's an antalgic gait. They spend less time on the sore leg. Dot dash rhythm, head dips towards the painful side. Stiff, maybe a fused hip. Body rocks side to side. Then there are named gaits. Friedrich Trendelenburg described the show's weak hip abductors on the standing leg. The pelvis drops on the opposite side when they lift that leg. High stepping gait, lifting the knee high, seen with foot drop, maybe from peroneal nerve issues. Helps clear the foot. Spastic gait linked to cerebral palsy. Ataxic gait, broad-based, irregular, suggests cerebellar problems, coordination issues.
Okay, so after that general look and gait check, you focus more closely on the problem area.
Precisely. Now you need proper exposure. You need to see the joint itself, plus the one above and the one below it. And crucially, expose the opposite limb too. Comparison is key. Asymmetry often signals pathology. Make sure the patient's comfortable, of course. Then you look really closely at the skin over the joint. Scars, bruising, erythema that's redness, suggesting inflammation, maybe infection, ulcers. Think arterial, venous, neuropathic causes, rashes. Sinuses, those little tracks. Could mean deeper infection like osteomyelitis, bone infection, hair loss, changes in sweating, pigmentation changes like cafe au lait spots, raised lesions like neurofibromas, all potential clues. Then look at the soft tissues. Swelling could be an effusion, fluid in the joint, or distinct lumps. Where are they coming from? Which layer? Muscle wasting. Is it disuse from pain or a nerve problem, a neuropathy? Muscle fasciculations, those little twitches, suggests lower motor neuron issues. Finally, the bones. Any abnormal alignment compared to the other side. Obvious deformity.
Moving from look to feel. Time to use your hands.
Yes, but carefully. The source stresses asking first if any area is tender. Watch their face as you palpate. Don't cause unnecessary pain. Good tip, especially with kids. Feel the normal side first. Gives them confidence, gives you a baseline.
And what exactly are you feeling for?
Yeah. On the skin, sensory changes. Does loss follow a dermatome, a specific nerve root pattern? Or is it glove and stocking, suggesting peripheral neuropathy like in diabetes? Screen with light stroking first. If abnormal, you need a full neurological exam. Soft tissues. Feel for tenderness. Can you pinpoint which structure hurts? Skin, fat, bursa, nerve, artery, tendon, muscle. Feel for lumps, effusions. The source gives that acronym, SWELLED, for assessing lumps. S, start, when, how. W, where exactly. Layer. Move with structures. E, external features, size, surface, margins. L, lymph nodes nearby. L, liquid inside. Fluctuate, transilluminate. I, internal features, hard, soft, tender. N, noise, thrill, brute, suggests vessels. G, generally other lumps. Also feel for pulses. Distal pulses are vital. Check capillary refill, press the nail bed. Should pink up in under 2 seconds. The source is clear. Document neurovascular status before and after surgery. Acute circulation loss. Surgical emergency for bones. Carefully feel their contours. Any abnormal shape. Tenderness. On superficial joints like the knee, you can feel the joint line itself. Tenderness there is a big clue.
And the final part of the Amplis framework, move.
Right. Move has 3 stages. First, active movement. Ask the patient to move the joint themselves as far as they comfortably can. Note the range, note any pain limitation. Second, passive movement. You gently move their limb through the range. Note the full range. Record it in degrees. A goniometer helps accuracy here. Now compare active versus passive. If they're the same range but it hurts, usually pain or stiffness in the joint. If passive range is greater than active range, usually points to muscle weakness. The joint can move, but they can't actively move it that far. The source lists all the movement terms. Flexion, extension, lateral flexion spine, abduction away from midline, adduction towards midline, internal, external rotation, supination, palm up, pronation, palm down, circumduction, circular inversion, sole out, retraction, back. The third part of move is assessing stability. Static stability comes from ligaments, bone shape, dynamic stability from muscles, tendons crossing the joint. You test dynamic stability by having them move against your resistance, which leads nicely into grading muscle power.
How is muscle power graded?
Using the Medical Research Council or MRC scale, it's a 0 to 5 system. Grade 0, no contraction at all. Grade 1, flicker of contraction but no movement. Grade 2, moves fully but only with gravity eliminated, like sliding arm on a table. Grade 3, moves fully against gravity but no extra resistance. Grade 4, moves against some resistance but weaker than normal. Grade 5, normal power moves against strong resistance. And assessing power connect back to understanding the whole pathway, the muscle itself, the peripheral nerve supplying it, and the specific nerve root in the spine it comes from. Table 35.5 in the source lengths nerve roots, C5T1 for arms, L1S for legs, to sensation areas, motor functions, and key reflexes like biceps, triceps, knee-jerk, Achilles. Finding weakness helps trace the problem.
That's brilliant for pinpointing the issue along the nerve path. But this raises an important question. What about joints that seem to move too much, hypermobility?
Yes, good point. Assessing joint hypermobility is also part of the exam. Excessively mobile joints can be unstable, painful. The source describes the Baton score. It's a standard screening tool for generalized hypermobility. Scores out of 9. You get points for. Palms flat on floor, knees straight, 1 peat more. Elbows bend back 10 degrees, 1 peat each side. Knees bend back 10 degrees, 1 peat each side. Thumb touches forearm on same side, 1 peat each side. Little finger bends back 90 degrees, 1 peat each side. Peter Baton and Francis Horan developed it. It tells you if someone's hypermobile, but not why. It's a screening tool.
So this whole look, feel, move approach, plus power grading, plus checking hypermobility, that gives you the core framework for any MSK exam.
Exactly. It's the structured way to gather objective data. The summary box reinforces it. Hand hygiene chaperone, introduce, gait, look, feel, move, consider special tests, do a relevant neurological exam, and check pulses. Systematically comprehensive.
Okay, general principles down. Let's apply them. Starting with the spine. What's key about its structure when we examine it?
Well, the spine's complex. 33 vertebrae, 23 discs, lots of ligaments, muscles. When examining standing, you check alignment in 2 planes. From the front, the coronal plane, it should be straight. Plumb line from C7 should drop through the gluteal crease. Any deviation, tilt or scoliosis. From the side, the sagittal plane, look for the 4 normal curves. Cervical and lumbar lordosis, inward curves. Thoracic and sacral kyphosis, outward curves. The source has figures showing these.
Taking the neck, the cervical spine first. What do you look for?
Look at shoulders, upper back muscles, paraspinals, shoulder blades, scapulae. Check for symmetry, muscle wasting. Look at neck skin creases, are they symmetrical? Shoulders level. And assess the normal cervical lordosis, that gentle inward curve, usually 20-40 degrees.
And feel for the cervical spine.
Stand behind, maybe support their chin. Palpate the soft tissues, feel for paraspinal muscle spasm. Then feel the bony bits the spinous processes down the middle. Any tenderness, misalignment. C7T1 are usually the most prominent bumps at the base of the neck.
What about move? What are the key neck movements?
3 planes. Flexion, chin to chest, about 45 degrees, and extension, head back, look up, about 55 degrees. Rotation, look over each shoulder, about 70 degrees each way. Lateral bending, ear towards shoulder, about 40 degrees each way. Figures in the source show these clearly.
And the neurological exam here targets which nerve roots for the arms.
Focuses on C5 to T1 nerve roots. They form the brachial plexus, supplying the arms. So you test sensation in their dermatomes, power in the muscles they supply, and check reflexes like biceps, C56, brachioradialis, C6, triceps, C7, Refer back to that nerve table.
And there's a specific special test mentioned for the cervical spine.
Yes, Sperling's test. Checks for nerve root entrapment, maybe a disc bulge or bone spur, pinching the nerve. The examiner turns the patient's head to the symptomatic side, extends the neck slightly, then applies gentle downward pressure on the head. If this reproduces their arm pain or tingling radiating down the arm, positive test, suggests nerve root irritation on that side, named after Roy Sperling and William Scoville.
Okay, moving down to the thoracic spine, the upper back. What are the main issues encountered here?
Mostly pain and deformity. Structurally, remember the normal thoracic kyphosis, that outward curve, convex back, usually 20-45 degrees.
What do you look for specifically in the thoracic region?
Need to see the whole back, neck to gluteal cleft. Check the skin carefully, cafe au lait spots, hairy patches. Could hint at underlying hidden nerve or bone issues from development.
Yep.
From the front. Shoulder or rib cage asymmetry might suggest scoliosis. From the back, iliac crest heights level. Pelvic tilt, any lateral curved scoliosis often involves rotation too. See a rib hump, that's rotation pushing ribs back. From the side, assess the kyphosis. Is it normal or increased?
And feel.
Palpate along the spinous processes, the paraspinals. Often helps to support their pelvis while you do this.
Move. Not much movement here, but that scoliosis test is important.
Right. The rib cage restricts thoracic movement a lot. The key test is the forward bending test, or Adams test, for scoliosis. Patient bends forward, tries to touch toes, knees straight. You look from behind and the side. In structural scoliosis, a fixed curve with rotation, that rib hump gets more prominent on the convex side as they bend. That's diagnostic. In functional scoliosis, a flexible curve, maybe from leg length difference or spasm, the spine tends to straighten on bending, and there's no rib hump. You can also use lateral bending to see how flexible a scoliosis curve is.
Now, the lumbar spine, lower back. Pain here can be tricky, often referring elsewhere.
Definitely. What's fascinating here is lumbar spine irritation or nerve root issues there can send pain down the leg, making you think it's a hip or knee problem. So lumbar exam has to include checking the pelvis, hips, lower limbs, gait, even peripheral pulses. Always consider referred pain.
What do you look for in the lumbar area?
From the back, skin at the base, hairy tufts, dimples, could suggest spina bifida occulta. Look at spinal muscles prominent or asymmetric from spasm. From the side, the normal lumbar lordosis, that smooth inward curve, 40-60 degrees usually. Loss of lordosis, a flattened back. Very common, often due to pain and muscle spasm.
And when you feel the lumbar spine?
Palpate the spinous processes. Feel for a step off. One vertebra feels shifted forward compared to the one below. Can indicate spondylolisthesis, that forward slip.
How about move? How do you assess flexibility, especially knowing the hips contribute so much to bending forward?
Assess flexion, extension, lateral bending, rotation. You're right, a lot of forward bend comes from the hips. To measure lumbar flexion specifically, the source describes marking T12L1 and the lumbosacral junction. Measure the distance, patient bends forward, measure again. The increase in distance shows lumbar flexion range, normally 40-60 degrees. Lateral bending, slide hand down the side of the leg, rotation. Hold the pelvis still, watch the shoulder girdle twist relative to pelvis. Range is small, 3-18 degrees.
This is where those special tests using the leg come in, targeting lumbar nerve roots.
Exactly. Lasag's straight leg raise is the classic. Patient lies flat, lift the leg straight up. Positive if it reproduces their sciatic type leg pain, usually between 30-70 degrees. Stretches the sciatic nerve, L4-S3 roots. The technique described: bend knee first to show hip moves okay, then straighten and lift. Note hamstring angle. Lower slightly, then dorsiflex the ankle, adds tension to L5-S1. If pain returns, positive. Named after Lasag, though his student force did it first. Then there's the contralateral stretch test. Lift the good leg. If that causes pain in the symptomatic leg, strongly positive. Very suggestive of nerve root compression, often a disc herniation.
So pulling the spine examination all together.
The summary box hits the key points. Inspection standing, front backside. Palpation, posterior bony bits paraspinals. Move. Flexion, extension, lateral rotation, bending. Neurological check, sensation, tone, power, reflexes, proprioception, coordination. Special tests, Sperling's forward bending, Lasag's contralateral stretch. Covers all bases.
Okay, let's shift to the upper limb. We'll dive into the hand and wrist as one functional unit, as the source suggests.
Makes sense. They work so closely together. You've got the extrinsic muscles, with bellies in the forearm acting via long tendons, and the intrinsic muscles, starting and ending within the hand itself. Generally, flexors are on the palm side, volar, extensors on the back, dorsal.
What do we look for in the hand and wrist?
Start with posture. Compare both hands. Nerve issues cause classic resting positions, like ulnar nerve clawing. Skin. Scars, discoloration, cafe au lait, redness, hair loss, nails, psoriatic pitting, tight bands in palm, Dupuytren's contracture, Baron Dupuytren, loss of sweating. Could be complex regional pain syndrome, soft tissues, swellings like a ganglion cyst, often back of wrist, or swelling near the radial styloid, de Quervain's tenosynovitis, Friedrich de Quervain. Muscle wasting is crucial. Look at the thenar eminence, thumb base, hypothenar, little finger base, intrinsics between adacarpals on the back. Compare sides. Wasting patterns point to specific nerves, table 35.6. Thenar suggests median nerve, C-acetalicutner. Intrinsic wasting suggests ulnar nerve, T1. Figures show examples. Bones, obvious deformity. Dinner fork from a Colles fracture, Abraham Colles. Table 35.7 lists typical finger joint deformities and arthritis. Heberden's nodes, DIPJ, OA, William Heberden. Bouchard's nodes, PIPJ, OA, Charles Bouchard. Boutonniere, PIPJ flex, DIPJ extended, RA. Swanek, PIPJ extended, DIPJ flexed, RA. The thumb, RA. Ulnar drift, MCPJs, RA.
When we move to feel, what are the specific techniques, especially for sensation?
Skin sensation. If like stroke is off, use 2-point discrimination. Use a paper clip. Find the minimum distance they can feel 2 distinct points. Check key nerve areas shown in table 35.8, ulnar, median, radial. The pen sliding test checks. Sweating, pen slides easily on non-sweaty skin, nerve issue, drags on normal skin. Good for autonomic check. Soft tissues, feel muscle bulk, tendon thickening. Palpate bony points, radial ulnar styloids, anatomical snuff box. Tenderness here after trauma, think scaphoid fracture. Check sensation in those key nerve zones. Radial side index finger, median snuff box radial, ulnar side little finger, ulnar. Blood vessels feel radial and ulnar pulses. Check capillary refill, 2-6. Do Allen's test, Edgar Allen, before surgery. Lock both arteries, pump fist till pale, release one, check refill. Test artery patency, palmar arc adequacy, nerves. Feel for signs of compression, especially median nerve at wrist, carpal tunnel. Tinnell's test, Jules Tinnell. Tap over nerve, tingling and nerve distribution. Suggests irritation compression. Phelan's test, George Phelan. Hold wrist fully flexed 30-60 secs. Reproduces tingling and median distribution. Positive for carpal tunnel. Figures show these. Palmar fascia. Feel for thickening. Pits. Cords. Dupuytren's disease. Often ring little fingers. Bones. Palpate wrist bones. Hand bones. Snuff box tenderness for scaphoid fracture is key after trauma. Palpable volar structures. Scaphoid tubercle. Pisiform. Hook of Hammett.
And how do we assess move for the hand and wrist?
Wrist. Flexion extension use, prayer and back-to-back hand positions as guides. Ulnar radial deviation guide the hand side to side. Hand, general screen roll fingers from full extension into a fist. Might reveal trigger finger. Test power. Gripping your fingers tests forearm flexors and wrist extensors bracing. Extending, spreading fingers against resistance tests intrinsics, mainly ulnar nerve. Specific finger flexor tests. Superficial tendon, hold other finger straight. Ask patient to bend test finger at PIPJ. Profundus tendon, stabilize all but DIPJ. Ask patient to bend just the tip. Thumb thenar tests. Opposing thumb to little finger tests several median nerve muscles together. OK sign, thumb tip to index tip. Tests flexor pollicis longus, median nerve branch. Lifting thumb off table, palm flat. Tests extensor pollicis longus. Froment sign, Jules Froment, tests adductor pollicis, ulnar nerve. Patient grips paper between thumb beads his side. Pull paper away. If thumb IP joint flexes strongly, positive they're using median nerve muscle, FPL, to compensate for weak ulnar nerve muscle, adductor. Abductor pollicis brevis, median nerve test. Palm up, lift thumb straight up towards ceiling, resist you pushing down. Figures illustrate many of these.
That is quite the detailed assessment. Let's recap the hand-wrist summary.
Sure. Summary box 35.4 guides it. Inspection, standing spine, looking for all those signs. Palpation, bony points joints. Movements, wrist-hand ranges. Special tests. Allen's vascular, Tennell's, Phelan's, median nerve. Froment's, ulnar nerve. Finkelstein's test is mentioned for de Quervain's, though the technique isn't described in the provided text. Harry Finkelstein was a notable hand surgeon, though.
Okay, moving up the arm, the elbow, how's that joint structured?
Primarily a hinge joint, formed by ulna and radius, forearm bones, meeting the humerus, upper arm bone, allows mostly bending and straightening.
Look, what do we focus on for the elbow?
Skin. Check extensor surface, back of elbow for psoriasis, soft tissues, swellings like olecranon bursa over the tip, rheumatoid nodules, gouty tophi, muscle wasting, biceps for triceps back. Importantly, remember, ulnar nerve compression at the elbow causes wasting distally in the hand, hypothenar intrinsic muscles. So check the hand too. Bone. Look at the carrying angle, that slight outward angle. Valgus, 9-14 degrees normally. Deviations. Cubitus varus, gunstock, angle reversed, often after fracture. Cubitus valgus, increased angle. Check for hyperextension. Beyond straight, 5 degrees is okay.
And feel around the elbow.
Soft tissues. Feel for a fusion, cross fluctuation. Gently roll the ulnar nerve in its groove behind the medial epicondyle. Test distal sensation, especially ulnar nerve area. Check distal pulses, bones. The three landmarks form an equilateral triangle at 90-degree flexion, mediolateral epicondyles, olecranon tip. Palpate the radial head. Feel it rotate as you pronate supinate forearm. Feel medial epicondyle, olecranon fossa behind.
Hinge joint, yes, but also that forearm rotation happens here too.
Exactly. Main movements. Flexion extension. Normal range, about -5 degrees, hyperextension to 150 degrees flexion. Ask them to bend and straighten fully. Pronation, supination. Assess with elbow bent at 90 degrees, isolates forearm rotation. Palm up, supination, 90 degrees. Palm down, pronation, 70 degrees. Figures show these.
Special tests here often relate to tennis or golfer's elbow, those common issues.
Right, they're inflammatory processes where forearm muscle tendons attach at the epicondyles. Medial epicondylitis, golfer's elbow. Inflammation at medial epicondyle, common origin of flexors pronator, find tenderness there. Diagnostic test, pain reproduced when patient flexes wrist against resistance. Lateral epicondylitis, tennis elbow. Inflammation at lateral epicondyle, common origin of extensors. Tenderness usually just distal to epicondyle over extensor carpi radialis brevis. Diagnostic test, pain provoked when patient extends wrist against resistance, especially with elbow straight.
Lots packed into that elbow exam. Let's recap.
Summary box 35.5 hits the marks. Inspection, standing front back supine, checking angles, wasting deformities. Palpation, bony landmarks. Movements, flexion extension, pronation, supination. Special tests, specifically for tennis golfers' elbow.
All right, up to the shoulder. Pain here isn't always straightforward, is it? Can come from elsewhere.
That's fascinating here is shoulder pain is notorious for being referred. Often felt anterolaterally, but could stem from the cervical spine, heart, mediastinum, even the diaphragm. Always keep referred pain in mind.
Look for the shoulder.
Observe how they hold the arm, attitude. Skin, surgical scars, common spots. Anterior delta pectoral side, deltoid split arthroscopy portals. Posterior arthroscopy, soft tissues, wasting. Deltoid wastum common after dislocation, axillary nerve injury, or rotator cuff muscles, supraspinatus, infraspinatus, etc., can waste with chronic cuff issues. Bone, obvious deformity, middle third clavicle fracture is common. Suspect dislocation, look for loss of normal rounded contour. Anterior dislocation, most common, gives anterior bulge, squared off look.
And feel around the shoulder.
Try to differentiate. Is pain generalized, joint, neck, or localized, like AC joint? Skin, test sensation in the regimental badge area, upper outer arm. Axillary nerve supplies this. Loss of sensation here. Suspect axillary nerve damage, often post-dislocation. Figure 35.22 shows this. Bones, palpate AC joint, sternoclavicular SC joint, clavicle itself.
How do you separate true shoulder joint motion from just scapular movement?
Crucial distinction. Patients with painful shoulders compensate using scapulothoracic motion, shoulder blade on chest wall. To assess true glenohumeral motion, stabilize the scapula. Thumb on coracoid process front, fingers on spine of scapula back. Start assessing from neutral, arms at sides, elbows straight, palms forward, note pain throughout range. Figures show movements. Specific movements ranges. Forward flexion, arm straight up, 0, 180 degrees. Extension, arm straight back, 0, 30 degrees. Abduction, arm out to side, 0, next 180 degrees. Remember, first 60 degrees, mostly glenohumeral, then scapula rotates significantly. Final bit is scapulothoracic. Adduction, arm across body, touch other shoulder. Internal rotation, hand up back, note spinal level, normally T7-9. External rotation, elbows 90 degrees tucked in, move hands out, 0, 40 degrees.
Special tests are key here, particularly for things like impingement.
Yeah, impingement syndrome is common. Rotator cuff tendons, supraspinatus, get squeezed under the acromion during abduction internal rotation, causes tendinitis, even tears. Pain weakness on those movements. Painful arc test. Slowly abduct arms. Pain specifically between 60 and 120 degrees, positive for impingement. Job's test, empty can test. Test supraspinatus. Arm abducted, 90 degrees, in scapular plane, 30 degrees forward, fully internally rotated, thumb down. Resist you pushing down. Pain weakness, positive, named after Christopher Job. Hawkins test is mentioned, but not detailed here. Richard Hawkins, another key figure. Shoulder instability. Humeral head slips partly, subluxation or fully dislocation out of socket. Anterior, posterior, inferior, multi-directional types. Apprehension test for anterior instability. Supine or standing. Elbow 90 degrees, shoulder 90 degrees abducted. Slowly externally rotate. Patient feels apprehension like it'll pop out or resists. Positive. Relocation test and sulcus sign are also listed for instability, but techniques aren't detailed in this source material.
That's a really comprehensive look at the shoulder.
It covers the essentials. Summary box 35.6 outlines it. Inspection, standing front side back supine. Palpation, shoulder girdle. Movements, all directions, separating glenohumeral scapulothoracic. Special test for impingement. painful Archdrups-Hawkins, and instability, apprehension relocation sulcus sign. Also reminds you to assess rotator cuff specifically, AC joint pathology, and differentiate frozen shoulder versus OA.
Okay, let's move down the body now to the hip. Big ball and socket joint. What kind of problems do we typically see?
Lots across all ages. Table 35.0 lists common ones. Kids, developmental dysplasia, transient synovitis, Perthes disease, York-Perthes, septic arthritis osteomyelitis, slipped capital femoral epiphysis. Adults, primary secondary OA, inflammatory arthritis, avascular necrosis, femoroacetabular impingement, FAI, labral tears, referred pain, juvenile idiopathic arthritis carrying over. Key point: hip pain assessment often needs checks of spine, abdomen, pelvis, groin, thigh, gynecological exam in women too, and Thomas's test is named after Hugh Owen Thomas.
What are we observing for the hip?
Patient standing, front side, back. Look for walking aids, heel raises, leg length difference compensation. Skin, scars, sinuses, infection. Soft tissues, muscle wasting, quads, glutes arthritis, nerve issue, bone posture, limb posture, adduction deformity. Fixed adduction in severe OACP makes leg look short due to pelvic tilt that's apparent shortening.
And feel around the hip region.
Soft tissues, tenderness over greater trochanter, side bony point. Suggests trochanteric bursitis or abductor tendon issues, bone. Palpate landmarks, ACIS, front pelvic points, iliac crest, top pelvic ridge, greater trochanter. Other areas: inguinal ligament, check for hernia nodes. Femoral artery pulse, midpoint ACIS pubic tubercle.
Move. How do we isolate true hip movement from pelvic tilting?
Crucial point. True hip motion stops when the pelvis starts moving. To isolate it, stabilize the pelvis. Put a finger hand on the opposite ACIS. Watch feel for movement there. When it moves, you've hit the limit of true hip motion. Assess passive movement, patient supine. Hip flexion, knee to chest, 120 degrees. Modified Thomas's test is best for this and checking fixed flexion deformity, FFD. Patient rolls into ball, flexes both hips. Hold one knee to chest, fixes pelvis. Patient extends other leg down, can't reach couch. Angle FFD, repeat other side. Hip extension, leg back, measured prone, face down, 0-10 degrees. Rotation, hip knee flex 90 degrees. Rotate lower leg in internal rotation 45 degrees and out external 45 degrees. Node angle tibia makes with vertical. Pain at end range suggests inflammation. Abduction, leg out 40 degrees. Adduction, leg across 30 degrees. Hand on opposite ACIS to detect pelvic tilt. Figures show these.
Okay, this is where it gets really interesting. Hip special tests, including gait.
Trendelenburg test. Friedrich Trendelenburg. Tests hip abductor strength, gluteus medius minimus. Patient faces you, uses your hands for balance, stand on one leg then other. If pelvis drops on the lifted side when standing on weak leg, positive test. Weak abductors on stance leg can't hold pelvis level. Leg length discrepancy, LLD, can be hip, femur, tibia, ankle, foot issue, real LLD, bones different lengths. Measure ACIS to medial malleolus, apparent LLD. Deformity, like FFD, causes pelvic tilt, makes leg look short. Measure midline, xiphosternum umbilicus, to medial malleolus. Try to square pelvis or position legs identically. Can use blocks under short leg till pelvis feels level to measure apparent LLD. Causes in hip, OA, fracture dysplasia, AVN, FFD, summary box 35.7. Gait, hip disease changes it. Table 35.11, summaries in 35.8, lists common limbs. Weak Trendelenburg. Painful, antalgic, dash. Unbalanced, ataxic. Loss of muscle control. High stepping foot drop. Deformity, in towing. Impingement tests. Avadii, flexion adduction, internal rotation, reproduces pain in FAI. Faber, flexion abduction, external rotation, force shape, reproduces hip pain or SI, joint pain. Snapping hip. Patient feels shears snap pop. Walking, rising. Usually tendon, so ASI-TB snapping over bone. Often painless but can cause bursitis.
To wrap up the hip exam.
Summary box 35.8 covers it. Inspection, standing front side back gait, supine. Palpation, anterior joint adductor, origin greater, trochanteriskal tuberosity. Movements, flex stab dadentex rotation, stabilize pelvis. Special tests, Thomas's Trendelenburg leg, length, impingement, snapping hip.
Right, next up. The knee, synovial hinge joint, 3 compartments. What's involved in its extensor mechanism?
So that's the system for straightening the knee. Includes quadriceps muscle, quad tendon, patella's kneecap, patellar tendon, tibial tuberosity, bump on shin where it attaches. Also key ligaments. ACL, stops tibia sliding forward. PCL, stops tibia sliding back. MCL, resists inward valgus force. LCL, resists outward varus force.
Look for the knee.
Patient standing, front sides, back, both knees, walking aids, braces, skin, scars, soft tissues, quad wasting, swelling, front behind knee, bone. Overall alignment varus, bowlegger or valgus, knock-kneed. Measure distance between knees, varus, or ankles, valgus. Side view, fixed flexion. Recurvatum, hyperextension.
Gait observation specific to the knee.
Antalgic gait, painful limb, common in OA. Varus thrust knee collapses more into bow leg on weight bearing, medial OA sign.
Feel. How do you check for that knee effusion, the fluid?
Detecting fluid is key. Small, moderate effusion. Fluid displacement stroke test. Stroke up medial side to empty fluid into suprapatellar pouch. Hand below patella, check gutters for refilling. Large effusion. Patellar tap test. Push fluid down from above patella. Tap patella firmly. Feels like it's floating. Taps down on femur. Positive. Also feels soft tissues. Tendons. Quad patella rupture. Feel for gaps. Bones. Tibial tuberosity, inferior patella pole, patellar facets, ligament origins, insertions, joint line, mediolateral tenderness, here sensitive for meniscus. Popliteal swellings, patella height.
Move. Primarily hinge. But how do we assess range and extensor function?
Flexion bending, 0 Lanish, 135 degrees. Extension, straightening, 0 degrees to maybe Manus is 10 degrees hyperextension. Figures show range. Assess hyperextension, hand under distal femur, lift ankle, measure ankle lag test, checks extensor mechanism integrity. Patient lifts straight leg, 10 degrees, bends knee slightly. Tries to re-straighten in air, can't fully straighten, positive lag. Significant quad weakness rupture. Differentiate fixed flexion knee versus hip. Sit patient up, knees off couch edge, removes hip effect. Passively extend knee, still can't straighten. Deformities in the knee.
Special tests for ligaments are absolutely crucial for knee stability.
Hugely important. Collateral ligaments, MCL, LCL. Flex knee 40 degrees, relaxes posterior capsule. Tuck leg under your arm. Apply valgus stress, push knee in, ankle out for MCL. Apply varus stress, push knee out, ankle in for LCL. Feel over ligaments, assess laxity, excess opening versus other side. Endpoint, firm, soft limb. Figures show this. MCL valgus stress at 30 degrees, LCL outer stress at 10-30 degrees, instability and full extension, suggests more severe injury involving posterior structures too. Check peroneal nerve with lateral injury suspicion. ACL, anterior cruciate. Lachman test, John Lachman, is most sensitive. Knee flex 15-30 degrees, stabilize femur, pull tibia forward gently. Laxity or soft no, endpoint versus other side. Positive. Might be negative in chronic tear if some scars to PCL. Anterior draw test, knee 90 degrees flex. Check for posterior sag first, PCL, posterior cruciate. Main restraint to posterior tibia movement, grade laxity at 90 degrees. Look for posterior sag at 90 degrees. Posterior draw test most reliable. Knee 90 degree flexion. Look for posterior sag at 90 degrees. Posterior draw test most reliable. Knee 90 degrees flexed. Push tibia posteriorly. Compare laxity.
10 millimeter translation suggests PCL plus possibly posterolateral corner injury. Check PLC2. Figures illustrate these tests. Menisci. Palpable joint line tenderness is most sensitive sign. Flex knee 90 degrees, palpate mediolateral joint lines. Tenderness suggests tear. Mechanical symptoms, locking, catching, also suggestive. Posterior medial tears often hurt with deep squatting. McMurray's test, Thomas McMurray. Supine, hip knee flexed, brace lower leg, palpate medial joint line, apply valgus stress, externally rotate legs, slowly extend knee. Click clunk over medial line, suggests medial meniscus tear, not perfectly reliable but helpful. Patellofemoral joint, patella tracks in femoral groove. Truckley. Assess patellar tracking. Sit patient, legs off couch, knees 90 degrees. Slowly extend knee. Watch patella sudden lateral shift near extension. J sign. Maltracking. Patellar apprehension Fairbanks test. Sir Harold Fairbank. Tests instability. Try to push patella laterally, knee extended or slightly flexed. Patient gets apprehensive, feels unstable. Contracts quad. Positive for instability. Patellar tendon. Distal extensor mechanism. Rupture, usually at bone junction. Can't actively extend fully. Swelling. High writing patella alta. Palpable gap. Active extension lost if retinacula torn too.
That covers a huge amount of the knee's complexity.
It does. Summary box 35.9 pulls it together. Inspection, standing frontside back gait, supine. Palpation, extensor mechanism joint lines, collateral hamstring, stibule, tuberosity, fibular head. Movements, flexion extension. Special tests, patellar apprehension extensor mechanism, cruciates collaterals menisci.
Okay, final stop. Grounding our exam in the foot and ankle. How's the foot structured?
Divided into 3 parts. Hindfoot, calcaneus, talus ankle bone. Midfoot, navicular, cuboids, cuneiforms. Forefoot, metatarsals, phalangistos.
Look, what are we observing for foot and ankle?
Standing. Look at whole limb alignment, pelvic tilt, LLD, knee issues, rotation, contractures higher up. Focus on foot shape, forefoot from front. Side view, medial arch normal, flat, high, behind. Hindfoot alignment, Achilles calcaneus line, normal heel valgus 5-7 degrees. Too many toe signs, seeing lateral toes, suggests forefoot abduction flat foot. Foot shapes, neutral skew foot, valgus hindfoot, adducted forefoot, metatarsus adductus, neutral hindfoot, adducted forefoot, pes planus flat foot, pes planus flat foot, pes cavus high arch. Figures show these. Causes of pes planus, summary box 35.0, normal variant, hyperlaxity, morphens, tarsal coalition, rigid, tibialis posterior dysfunction, causes of pes cavus 35.11, spinal issues, spina bifida, nerve disorders, Merle-Package, Charcot foot, post-compartment syndrome, Volkmann's contracture, named after Morphan, Charcot, Marie tooth, Volkmann, skin, bunion, red swelling, medial first MTPJ. Gouty tophi, thin fat pads, RA. Corn scaluses, nails, soft tissues, swelling. Muscle wasting dorsum between metatarsals needs full neuro exam. Bones, prominences, exostoses. Common forefoot deformities table. Clawhammer mallet toes. Hallux valgus virus describing joint positions.
Gait observations for foot and ankle.
High stepping gait, foot job. Painful antalgic gait, joint pain. Short propulsive phase, forefoot pain limiting push-off.
And what can their shoes tell us?
Inspect footwear for wear patterns, normal. Posterolateral heel worn, heel strike. Under big toe ball worn, toe off. Look at shoe construction supports, heel raise, width, depth. Check insoles too. Clues about compensation.
Let's move to feel. Sensation is particularly critical here, right? Especially with diabetes.
Absolutely vital. Check for reduced sensation, especially that glove and stocking pattern, diabetes neuropathy. Soft tissues. Find pulses. Posterior tibial behind medial malleolus, dorsalis pedis, top of foot. Palpate tendons, tibialis anterior extensors, dorsum, Achilles back, peroneals lateral, tibialis posterior medial. Feel for tenderness, gaps, thickening. Palpate sinus tarsi, space anterior to lateral malleolus, tenderness suggests sinus tarsi syndrome. Bones, feel for deformity, prominences, tenderness, ankle joint landmarks. Malleoli, anterior posterior joint lines, lateral gutter ligaments, endosmosis, front, medial gutter ligaments, subtalar joint facets. Mid-tarsal joints, talonavicular, calcaneocuboid, tarsometatarsal joints, TMTJs, specific structure, calcanees. Heel pain, common plantar fasciitis. Feel for tenderness on plantar aspect, numbness, burning, nerve irritation. Tendons, contracture, Achilles, head of talus dorsum, sustentaculum tali, below medial malleolus, spring ligament attachment, cuneiforms, MTPJs, web spaces, forefoot bones.
Foot and ankle movements are quite interconnected.
They are, involving ankle, subtalar, midfoot joints. Acronyms help describe combined deformities. PAED, pronation, abduction, eversion, dorsiflexion, typical flat foot. SAPI, supination, adduction, plantar flexion, inversion, typical clubfoot. Ankle joint, dorsiflexion, foot up, plantar flexion, foot down, 15 degrees. Test, dorsiflexion with knee bent and straight. More restricted with knee straight. Gastrocnemius tightness, equally restricted. Soleus tightness or joint issue. Weak plantar flexion. Achilles S1 root issue, figures show ranges. Subtalar joint allows inversion, version. Hold telar neck, patient moves heel side to side. Or hold talus, you move heel, normal range, small, 5 degrees each way. Inversion sole in, eversion sole out, figures show this. Mid-tarsal joint, hold heel, move forefoot medially, adduction 20 degrees, laterally abduction 10 degrees. Tarsometatarsal joint, hold midfoot, move each metatarsal up, down passively. Metatarsophalangeal joint, extension, toes up 70-90 degrees, flexion, toes down 45 degrees. Need 35-40 degrees dorsiflexion for normal toe off.
Lots of very specific tests here to really get a handle on foot and ankle problems.
Yes, they help pinpoint issues. Achilles tendon, feel muscle belly tendon. Gaps, tenderness, swelling. Haglund's prominence, Patrick Haglund on calcaneus. Retroachilles bursa, integrity test, Thompson-Simmons test. Theodore Thompson, Franklin-Simmons. Prone, squeeze calf. Ankle should plantar flex, no movement, rupture. Careful, patient might still tiptoe using toe flexors. Subtalar flexibility, stand on toes. Heel should move from valgus to varus, flexible. Coleman block test, Sherman-Coleman. Stand with lateral foot on block, medial foot big toe off edge. Look from behind, hindfoot force corrects. Mogul, stays varus, fixed. Flat foot flexibility. Windlass jacks tests, you and jack. Stand on toes, windlass arch forms flexible. Or stand flat. Lift big toe, jacks, arch forms it flexible. Failure fix flat foot. Ankle stability, often post-trauma. Anterior draw test. Foot slightly plantar flex off bed edge. Stabilize tibia, pull heel forward. Compare laxity to other side. Test anterior talofibular ligament. Syndesmosis instability, it might be felt. Squeeze test. Squeeze mid-calf. Pain at ankle. Suggest syndesmosis injury. Tilt test. Hold talus, not heel. Apply varus valgus stress to check talar tilt. PMT joint stability. Push each joint up, down. Standing x-rays help. Specific tendons. Tibialis anterior. Walk on heels, tendon. Active dorsiflexion inversion against resistance. Palpate muscle, tibialis posterior. Pathology causes posteromedial pain swelling, gradual flat foot, too many toes, heel valgus. Palpate tendon, integrity, single foot tiptoe test, can't lift heel, injury, insufficiency. Strength, hold foot plantar flexed inverted against resistance, dorsiflexors. Tendinitis common athletes, palpate. Test strength against resistance, foot drop. Causes, stroke, spine issues, nerve injury, sciatic peroneal, neuropathy, peroneal tendons, lateral pain swelling, history giving way, can get peroneal spasm, tarsal coalition or dislocation, provoke with dorsiflexion aversion. Test strength integrity, active web space for mass. Squeeze metatarsals, Mulder's quick, Jacob Mulder, quick pop with pain. suggest neuroma.
That is an incredibly detailed journey through the foot and ankle exam.
It really covers the ground. Summary box 35.12 recaps. Inspection, standing frontside back gait, supine. Palpation, ankle subtalar midfoot, forefoot, joints, tendons. Movements, dorsiflex, flex invertebrate. Special tests, flexibility, subtalar foot joint, stability, Morton's neuromass-specific tendon tests.
Wow. We really did deliver on that deep dive promise today, didn't we? We walked through that whole structured approach from Bailey and Love, covered everything mentioned in the material we had, from those crucial first steps, the detailed history, the 3 W's, function, meds, social context, all the way through look, feel, move. We unpacked gait analysis, fluid checks, MRC power grading, Beighton score for hypermobility, and then applied it all systematically. Spine, hand, wrist, elbow, shoulder, hip, knee, and finally foot and ankle. Hit all the anatomy, movements, special tests, even noted the historical figures. It feels comprehensive.
What's fascinating here, seeing how that systematic detail really works. You start by listening, truly listening, to the patient's story. Then you apply this structured observation and examination using tests designed to isolate specific structures and functions. It allows you to build this incredibly rich picture, to move beyond just where it hurts to figuring out why it hurts, which structure is actually causing the problem. That's really the path to mastery in clinical assessment, isn't it?
It really highlights how much you can learn just from careful history and hands-on examination when guided by such a rigorous process. You, listening, have now walked through all those expert steps.
You know, this raises an important question. We talked about how interconnected the MSK system is, how pain can be referred from miles away, how different conditions can look similar. So how does the sheer depth, the systematic nature of the exam we've just gone through, how does it actually help clinicians cut through that complexity? How does it help them avoid mistakes and truly nail down the real source of the problem, even when it's not obvious at first glance?
That's a fantastic question to reflect on. It really underlines why getting these fundamentals absolutely right is so critical. Thank you for joining us on this incredibly detailed deep dive. We genuinely hope you feel you've gained that deeper understanding, that sense of mastery over the process of musculoskeletal history and examination.